So I would now like to introduce our speaker to you. Christa Slatnik is a nurse practitioner in gynecologic oncology in Winnipeg, Manitoba. Christa has over 11 years experience working as a nurse with gynecologic oncology patients at Women's Hospital Health Sciences Centre, and she joined the team at Cancer Care Manitoba in 2012 when she graduated with her master's in nursing as a nurse practitioner. Krista's passion for helping support women and their families affected by ovarian cancer is a very personal one, and it began in 1998 when her mother, Cheryl Pragnell, was diagnosed with ovarian cancer. Unfortunately, her mom passed away in 2000. But Christa has been fighting the disease ever since, hoping to make a difference in the lives of those affected by the disease. And so she not only works in this field, she's been highly involved with our organization, Ovarian Cancer Canada, as the volunteer co-chair of our Walk of Hope in Winnipeg. She's also a Knowledge is Power presenter, going out into the community to raise awareness about ovarian cancer. And in 2013, Christa, along with her sister, received the highest volunteer award given by Ovarian Cancer Canada, and that is the Peggy Truscott Award of Hope. Not only has she been recognized for her work with our organization, she's also been recognized for her work in the community. And on January 22nd of this year, Christa and her sister were awarded the Future Leaders of Manitoba Award, a very prestigious award recognizing her professionalism and her contribution to the community in Winnipeg. So I'm delighted to introduce Christa Slatnik to you, and we will now turn it over to her as she begins to present her PowerPoint, which will pop up in just a moment. So, Christa, thank you for being with us today, and please begin your presentation.
Okay, well, thank you everyone for having me. I'm going to be talking today about the common side effects for ovarian cancer patients that we typically see with the treatment that we offer. So treatment being a total abdominal hysterectomy and bilateral salpingoophorectomy. So both the uterus as well as cervix and both tubes and ovaries removed, and then also typically bilateral pelvic lymph node dissection, which is the lymph nodes being removed, which some of these side effects are caused from as well. So I'm going to go through some of the most common side effects that we see and some tips as to how to control those. And then if you have any questions about any other side effects that we didn't review today, then we can talk about those at the end. So nausea is one of the most common side effects that we used to see actually, because it is a very common side effect for the chemotherapy that we use for ovarian cancer. We typically use a platinum agent such as carboplatin or cisplatin and paclitaxel, and these two agents both do create a great deal of nausea. There's obviously some other potential causes of nausea that you can see here, but chemotherapy is one of the most common causes of nausea. So really what we've found is that over the past several years, there's been some new amazing medications that's come out that we've been able to actually prevent that nausea, knowing that there is such a high percentage of people that would otherwise be affected by nausea and vomiting without any sort of preventative medication. So nowadays, we find that being able to take medications such as Amend or Prepotent and dexamethasone combined does make a great deal of difference in order to prevent any nausea. So everyone probably has different regimens across the country, but this tends to be the most common one that we see, a tri-pack of Amend or Prepotent that you would take on day 1, 2, and 3, and then dexamethasone on day 2 and 3. And then you actually also get medications the day of your chemo through the treatment room, typically such as ondansetron or granisetron, and other medications that help prevent nausea as well. So we really don't see the nausea that is typically displayed in the movies still, or on TV. And we find that by being able to prevent it, it actually ultimately helps the overall experience for chemotherapy, because this is the typically most common symptom that people expect and are fearful of before starting chemotherapy. So there is treatment available, obviously, if there is still nausea after you try to prevent it. And there's different methods of treating it with anti-nausea medications. Gravel is the only medication that's available over the counter without a prescription, but there are some other options here that we typically use. In Winnipeg, we tend to use ondansetron or granisetron. The most common if the Gravel or Maxaran isn't working, but Gravel and Maxaran tends to be our first line therapy, and typically tends to be more than enough. We find that people typically fill their Maxaran prescription to have on hand just in case, which we usually recommend, as you don't always know when it's going to arise, but for the most part, people do tend to maybe take 1 or 2 Maxaran, if at all. Now, there's some tips, obviously, to try to control the nausea if you are still having issues with nausea. Food odors can trigger nausea, so it's good to try to avoid food odors. We find that foods that are cold or at room temperature do not smell as strong as hot foods, so typically trying to wait till the foods cool down before eating it can help. Avoiding the kitchen while foods are being made, because there's typically some aromas sometimes that tend to bother people when foods are cooking. Also, drinking through a straw can help reduce the odors from fluids, and fresh air actually can help. So if you can open a window in order to circulate the air and remove food odors, tends to help as well. Nibbling often tends to be very helpful. We usually recommend eating 6 small meals a day instead of 3 large meals. But also, if you're still having generalized nausea, some people find it helpful to eat a small amount every 15 minutes, just having a dry, starchy food in your tummy at all times, such as soda crackers, dry cereal, plain rice or toast, basically just so your tummy doesn't ever get completely empty. And then also just trying to find different foods that don't cause as much nausea for you. So some people find cereal with milk, noodles or rice soup, cottage cheese, canned fruit. It's really individual for everybody. So it's really finding those individual foods that you can nibble on throughout the day. Fluids are also very important. So you want to drink at least 8 to 10 cups of fluids a day if possible, and try to help prevent dehydration, especially if you are having issues with vomiting or diarrhea. And then also to try carbonated drinks such as ginger ale. Soft drinks are sometimes tolerated better after they're flat though, so just be careful with the carbonation, as sometimes that actually creates more indigestion. Soda water is good, clear soups, low-fat milks, and anything really that's a fluid can help with improving your overall fluid intake. It doesn't have to be water, because sometimes water isn't necessarily appetizing when you're not feeling very good. And then to just sip fluids throughout the day. Don't drink large amounts all at once. And mood has actually been shown to be a factor with nausea. So stress can make nausea worse. So try eating in a relaxed, slow manner if possible. But also just general stress relief can make a difference as well. Timing for some people is very important. So make sure that you try to eat when you're feeling your best. Certain parts of the day tend to be better for some people. Clothing can actually make a difference as well. So making sure that you have loosened your waistband around your tummy, because that can actually make a bit of a difference. And then posture actually can make a big difference as well. So lying down or resting quietly in a chair may help if nausea is worse when you're up and about. But sitting up for an hour after eating can also make a difference. With that said, lying down right after a meal can trigger nausea, but it's really dependent on what triggers nausea specifically for you. Reflux is another symptom that we tend to see, and it's somewhat related to nausea, because sometimes people feel that they're having nausea, but when we look into it further, it's actually more of a reflux from indigestion. For some people, it's irritating acid stomach juices that may leak outside of the stomach and into the throat, and then this obviously can cause irritation and sometimes muscle spasms in the throat. So some of the symptoms that people have when they say present with a bit of nausea, they may have some of these other symptoms that directs us more to realizing that it's actually from reflux. So sometimes there's feeling of something coming up in the throat, a sore throat, burning sensation in the throat, or a bitter taste in the back of the mouth, a tight squeezing sensation in the throat, sometimes even a lump in the throat or sticky mucus stuck in the throat. Coughing is actually one of the most common side effects that we tend to see that triggers the fact that the nausea might actually be related to reflux, and dryness in the throat as well, or hoarseness, and then swallowing problems. So in order to help manage reflux, it is important to acknowledge when the symptoms typically happen. So for some people, it's after eating, after drinking lots of liquid, even water actually can trigger reflux if you're eating or drinking lots of it. During or after exercise, bending over, lying down, sometimes even singing can aggravate it. And then some common triggers can also include coffee, tea, or cola, chocolate, alcohol, nuts, gum chewing, water, spicy foods, pastries, citrus. There's a variety of things, and it's really finding the specific foods that trigger it, because some people have no issues with chocolate, but they might have an issue with tomato-based foods. So it's really finding those individual triggers that are causing it for you. And then obviously one of the best ways to prevent it is to avoid the triggers if you're able to establish what those triggers are. We also find that losing weight, if you're overweight, can help decrease the pressure on your stomach, which can be causing some of that reflux. Changes in your diet may help decrease the symptoms, and also eating smaller, more frequent meals rather than large meals that might be putting pressure in your tummy as well. Do not lie down for at least 45 to 60 minutes after eating, because this will, with gravity obviously, sometimes reflux then back into the throat if you're lying down right away. And we usually recommend avoiding eating within 2 to 3 hours before bedtime, because it's going to be a longer period that you're going to be lying down for. You do want to try to keep your tummy empty for that time period if you can. So lying flat actually can make the symptoms worse, even if you do avoid the 2 to 3 hours eating before bedtime. So sometimes people need to raise the head of their bed about 4 to 8 inches. So you can do this by placing cinder blocks or wood or bricks, anything really that you can put underneath the head of the bed in order to raise it up. And if you're not able to do that, then sometimes sleeping with 2 or 3 pillows or a foam wedge can help. Sleeping on your right side has also been able to help for some people, so that might work. Avoiding clothing that's tight around the abdominal area, once again, that can make a big difference. Certainly the breathing have actually been able to help as well. So focusing on pushing out the stomach when you breathe, instead of pulling the stomach in or expanding the chest, can make a big difference. And do not bend or stoop unless absolutely necessary. So even things like gardening, exercising, that can really make a difference if that's triggering it for you. And also just maintaining a relaxed attitude in your activities. Now, if you do the tips in order to try to prevent the reflux and you're still having issues, there are ways to treat it. We typically recommend as needed medications such as antacids first. There's liquid versions such as Maalox and Gaviscon that we tend to find work a little bit better because the liquid actually can coat the esophagus as you swallow. But also Tums, Rolaids, at 30 to 40 minutes after meals and at bedtime can be helpful, or just taking as needed. But if you're finding that you're needing to take the antacids 2 to 3 times a day in order to stay comfortable, then typically taking medications regularly may help prevent the reflux. It's not a great quality of life if you're going through this roller coaster effect of needing to take antacids. So that's when we look at starting something regularly in order to prevent the reflux. So ranitidine 150 milligrams twice a day tends to be one of our most common go-tos. You can actually get that over the counter. It's just called Zantac typically. But there is also other similar medications that can be prescribed. And omeprazole is then our next line of therapy if the ranitidine doesn't work. So just know that if you are still dealing with issues with indigestion, that it typically can be resolved. There's a stepwise approach that we have to go to in order to treat it, but it typically can be resolved. So don't just deal with it, because it can actually greatly affect your quality of life. Another issue that we see very often with chemotherapy as well as postoperatively is constipation. So constipation is when the bowels don't empty, basically. They don't empty thoroughly and comfortably. That's the most important part. So a lot of people focus on the amount of days that you go to the bathroom, but it's actually more so on the consistency of the stool. So if you're having a bowel movement every day, but they're little hard stools, then those are constipated stools. Whereas if you're having a bowel movement every 2 to 3 days, but it's a nice, soft, easy to pass stool, and you're not having any issues with straining, then that's not a constipated stool. So the goal would be to go at least every 1 to 3 days, but really focus on the consistency of the stool. If your stool is hard and difficult to pass, then you know you're likely constipated, and you want to focus on some tips in order to try to prevent that from happening. Decreased physical activity obviously can contribute to constipation as well. So even though the main cause may be your chemotherapy or some of the pain or nausea medication that you're taking with the chemotherapy, other factors can contribute to that constipation. So controlling those other factors can make a big difference in how it's overall affecting you. So some tips if you do get constipated, or if you know you're prone to constipation already, then we typically recommend doing these tips in order to prevent it from getting any worse. So trying to eat at the same time each day, trying to have a bowel movement at the same time each day actually is really important to establish regularity, and ultimately never missing that urge. If you miss that urge that morning, then you might not get the urge again for the next day or two. So the longer the poop stays in there, the harder it's going to get. So really try to have a bowel movement when you get that urge. Drinking is really important in order to keep that stool hydrated. So drinking 8 cups or more of liquid each day. Your body needs the liquids obviously to keep the stool soft. And choose foods that are natural laxatives if you can tolerate them, such as prunes, prune juice, papayas, and rhubarb. Actually anything that contains fiber, such as fruits, vegetables, whole grain breads and cereals, nuts and seeds. Popcorn's actually really good as well. Natural brown and dried beans. Just be careful with bran, because if you are going to use bran, especially if there's any psyllium fiber involved, all bran buds have psyllium fiber, metamucil. Those are really good methods to help control constipation or prevent it. Unfortunately, if you're not hydrated, they can actually create more problems by bulking up the stool. And if you're not hydrated to keep that stool soft, it can actually create a more difficult stool to pass if it's a big, bulky, hard stool. So still use those methods if you can, but the most important part is to stay hydrated with that. Now, if you do still end up getting constipated, there's obviously some forms of treatment that we typically recommend. Now, depending on your history of constipation, if you're entering into treatment with chemotherapy with a history of constipation already, then sometimes we automatically recommend people go to at this stepwise approach. At other times, we wait and see, and if you're able to prevent the constipation with the preventative tips, then you may not need this, but know that this is always an option available. And every city will choose different regimens. This is one of the more common ones that we see and we use here at Cancer Care Manitoba, but it's really just knowing that it can be controlled, and don't just live with hard, difficult to pass stools. So at Cancer Care Manitoba, we recommend 2 stool softeners twice a day. If it's really mild constipation, it can just be once a day, but most often than not, we find people tend to need to go to this twice a day regimen, at least for the first week following chemotherapy, when we do tend to see that constipation is at its worst. Then at that point, if there's still 2 days with not having any benefit, and they're still having issues with hard stools or not able to pass their stool, then we recommend adding Senecot at bedtime. So the laxatives at bedtime do tend to help make a difference and help keep that the bowels moving, basically. Now, we don't often get to the point where we need to move to step 3, but it's just knowing that it's available. So knowing that you can still add more stool softeners and more laxatives to that regimen if absolutely needed. And you can go back and forth. So if you have to get up to step 3 in order to get things moving, then you can go back down to step 2. It's really a flexible regimen in order to move around, in order to ensure that you're really comfortable with regular bowel movements. If you do get to the point that you start needing step 3 regularly, there is Senecot S available, and and this comes with the stool softener actually in the Senecot, so it really decreases the amount of pills that you would need to take if you had to be on such an intense regimen. Step 4 is more so an as-needed part of the stepwise approach that we usually try to avoid, but it's just knowing that if you do need to add a suppository or a liquid laxative such as lactulose, those are options available, but we really do try to prevent getting to that point if we can. Another common symptom that we see is peripheral neuropathy. So this is one of the symptoms that has the potential to become chronic. So we're very careful with this one. Peripheral neuropathy is an injury to the nerves. Some of the nerves are involved in pain and temperature control. Others are involved with motor activities, vibration, movements, and positioning of the body. So peripheral neuropathy typically begins in the fingers and toes. That's why it's called peripheral, and then it moves slowly up the hands and the feet. It can cause pain, numbness, burning, tingling, swelling, and muscle weakness in varying degrees. The risk of developing peripheral neuropathy related to chemotherapy has no age relationship. There are, however, risks that may increase the chance that someone is more likely to develop peripheral neuropathy. Certain drugs, including cisplatin, carboplatin, docetaxel, and paclitaxel, can all cause peripheral neuropathy. It does only occur in approximately 4% of those with carboplatin. However, it can occur in approximately 52 to 64% of all cancer patients with paclitaxel. And as you know, that's one of the more common ones that we typically use for ovarian cancer. So this is a symptom that we do typically see at some point along the treatment. However, fortunately, there's only approximately 2 to 4% of cases that end up being severe and affecting overall quality of life and activities of daily living. So certain other factors that can actually increase your risk of developing peripheral neuropathy are having pre-existing conditions such as diabetes, HIV, hereditary neuropathies, a history of alcohol abuse, drug abuse, heavy smoking. People with severe peripheral neuropathy may have changes in their patterns of walking and may be at increased risk of falling. They can also have difficulty feeling with their hands and feet, and then obviously then be more at risk for frostbite, burning injuries. They might not be able to hold a fork or a pen, or they might not be able to button and unbutton their clothes or put on earrings. So these are all known as basically activities of daily living, which are obviously very important in order to maintain your independence and quality of life. So the fortunate thing is peripheral nerves do typically have the ability to heal. Frequently, but not always, the symptoms of peripheral neuropathy will slowly improve if the reason of the neuropathy is removed. So for example, if the neuropathy is caused from diabetes, then it's more so the diabetes that has to be controlled. But if it's controlled by if it's caused by the chemotherapy, then stopping the chemotherapy it typically is helping it resolve. Unfortunately, we never really know who these symptoms will improve on and who they will become chronic and potentially stay forever. So it's a symptom that we watch really closely while you're on treatment. If you do develop a little bit of peripheral neuropathy, even if it's just to the tips and the fingers and toes, we find that this is a very tolerable symptom that people are willing to live with if they're potentially curing the cancer. But there's still some tips that you want to take in order to protect yourself. So obviously checking the water temperature with your elbows before bathing or showering, using protective gloves. So I'm not going to go through all of these, but just know that it's really important to obviously take care of your fingers and toes, as sometimes there's things that you might not notice that you're going to be potentially hurting yourself because you can't feel it. It's also important to make sure that you're also protecting others as well. So just be careful with driving, obviously. Think about, are you able to feel and turn the steering wheel or the pedal brakes? Are you able to have a confident reaction time? Avoid falls, so use non-skid tub and shower mats. Ensure that your walkways are clear and you're removing throw rugs that you might be tripping on. Exercise is actually really important as well. So walk if you're able. Consider using a walking aid if you feel that it's going to provide some extra support. Try practicing walking on a variety of surfaces, typically with a physiotherapist. Focusing on strength training and endurance training can make a huge difference as well. Yoga is actually a really good exercise that you can do while you're actively on chemo, because this can help with your overall strength, mobility, but also your ability to have balance, which is sometimes a bit of an issue. And obviously, always let your nurse or your physician know when you're coming in for your appointments pre-chemo, because this is one of the most common symptoms that we have to be careful with the dosing when continuing on with your next cycle. Now, just know that if you do get peripheral neuropathy, there are treatments available. They don't always work necessarily on the numbness per se, but they can take away tingling and different burning or pain sensations that might be affecting your quality of life if you find that it's not going away on its own. So I'm not going to go through all of this, obviously, but nortriptyline and gabapentin tend to be more of the common ones that we use, but there's a variety of different options that are available. So sometimes it's just fine-tuning and figuring out which one works for you. Physiotherapy, occupational therapy, and also social work, counseling, and home care can also provide some benefit as well. So fatigue is actually another symptom that we tend to see just in relation to cancer in general, but also related to the chemotherapy. Fatigue is more than just sleepiness. It's a symptom that doesn't tend to necessarily go away even with a good quality sleep at bedtime. Although with that said, quality of sleep is very important, as sleep disturbances can obviously make fatigue worse. Chemotherapy, though, can lead to bone marrow suppression, which then obviously can lead to anemia from a low hemoglobin count. So all of these are factors that can greatly affect your fatigue level. Some tips if you do develop fatigue is to spend some more time awake than in bed during the day, obviously, and up and about if you can. Spend a normal amount of time in bed each day if you can. Stay physically and mentally active, and really try to do exercise if at all possible, even if it's just mild exercise or activity. Balance rest with activity, obviously. So still allow yourself little breaks and rest throughout the day. But if you are going to have a nap, have a short nap because you don't want to be affecting your ability to have a good quality sleep that night. And then just obviously trying to choose foods from all food groups, eating regularly throughout the day so you're not being fatigued from being hungry, and drinking lots of fluids can make a difference as well. And then, so I'm not going to go through all of these for time reasons, but I just wanted to show that there's a lot of tips that you can do in order to help control the fatigue if you do have it. The biggest thing is knowing your limits and taking care of yourself, and knowing that it can be different throughout the month, it can be different throughout the day. So really just allowing yourself that rest and talking about your feelings and how you're doing with the fatigue with family members, friends, and caregivers. And sometimes the support groups helps as well, because other women know what that feeling is like and what you're going through. Brain fog is another issue that we see with the chemotherapy that ovarian cancer patients get. So it's also called chemo brain or chemo fog. So it's typically thinking problems that some individual experience with cancer and cancer treatment. So sometimes forgetting where you left your keys, or maybe you put them in the fridge. So it's just try to have fun with it, and and joke about it. It does tend to be very temporary. It can affect your quality of life, obviously, depending on the severity of the short-term memory loss or whatnot, or decreased concentration, especially depending on your job. Sometimes we do find that the symptoms can linger. We typically see that they resolve by the 3-month mark, but after you're done your chemotherapy, but it can linger for up to a year. So most cancer care programs across the country have developed brain fog programs that specifically focus on how to deal with brain fog. So treatment tends to focus on health promotion, cognitive training, compensatory strategies, and restorative activities. So a brain fog program that we have here at Cancer Care Manitoba offers that, as well as by teleconference. So if you do live in a rural area of your province, ask the larger cancer care center in your area if they do offer a brain fog program, if it can be by teleconference, because a lot of the times they are trying to open up to rural areas as well to help with this. So once again, I'm not going to get into the palmar plantar erythrodysesthesia very much because this isn't as common that we see. This is more so with calyx, sometimes docetaxel, but these are some symptoms that and some chemos that we use for ovarian cancer. So I just wanted to put this in here to make sure that you guys were aware that this is a potential condition that we see as a side effect, and sometimes knowing that it's a potential helps you then prevent the symptoms from getting bad. So it's a dermatologic toxicity characterized by redness and pain on the palm of the hands and sole of the feet, occasionally on other body surfaces, but because it's more commonly on the hands and feet, it's known as hand and foot syndrome. A lot easier to say than the palmar plantar erythrodysesthesia. So we tend to call it hand-foot syndrome. Early signs include tingling or numbness sometimes to the palms of the hands or feet, dry furrowed skin that becomes reddened or darker, and then painless swelling or tenderness on the palms of the hand, pads of the fingers, soles of the feet, and behind the knees, groin, axilla, and below the breast. So the biggest thing is it really affect the skin integrity and cause risk for infection. We see sometimes actual cracks in the skin on the hands, and these cracks can then bleed and obviously open up and be prone to infection. So it's really important to be aware that this is a condition that is a potential, and if you do start developing these symptoms, to talk to your healthcare team, your gyne-oncology team, and ask about ways to prevent it. But these are some standard ways that you can help prevent it. So skin care and hygiene is really important. So just really making sure that you're keeping your hands clean and preventing infection that way. But keeping hydrated is one of the most important. We find that Utterly Smooth or any sort of lanolin cream, Utter Butter, anything like that is really good. So if you're starting to notice dry skin at all, then it's really a nice preventative way to prevent it from getting severe. Unfortunately, it's not always possible to prevent it. So if you do start finding that despite hydration, it's getting bad, please talk to your healthcare team. So there's just some tips here as to if you do start noticing it, there are some ways that you can try to prevent it from getting any worse at all. And then treatment obviously is available if the Utterly Smooth or the hydration isn't enough. Lymphedema is another one I'm going to touch on because it is it can be a very inhibiting symptom that some people live with for the rest of their life as well. So it's not a symptom that we see very commonly, but unfortunately, it can be a symptom that if you have your lymph nodes removed, especially during a staging surgery for your cancer, which most ovarian cancer patients do undergo, depending on the amount of lymph nodes that are removed, the more lymph nodes that are removed, the greater risk there is of developing lymphedema. So lymphedema is chronic swelling or edema of a body part caused by accumulation of lymph fluid as a result of insufficient lymphatic system. So if those lymph nodes are removed and preventing the proper drainage of lymph fluid, sometimes that lymph backs up in one or both of the legs, depending on which nodes were affected. So this can obviously lead to changes in the tissue, such as fibrosis and an increased risk of infection. So it can also just greatly affect the quality of life. So you can have a feeling of full or heaviness to the affected body part, decreased mobility in the affected body part. Clothing, watches, or rings can feel really tight, and an overall tightness in the skin. And obviously, abnormal swelling in the affected body part can lead to kind of mobility issues too if it's a great deal of swelling. There is some treatment available. It's typically more so supportive treatment, so reducing and managing the volume and decreasing the risk of complications is the ultimate goal. Lifelong self-assessment is really important in order to have optimal outcomes because this is typically a lifelong condition. Severity is dependent on the individual person and the individual cause, and also then sometimes the treatment. So complex decongestive therapy tends to be the most common form of treatment. This information and support in Manitoba is through the Lymphedema Association of Manitoba. There is a Canadian Lymphedema Association and typically provincial ones as well. So if you do have lymphedema, you can look them up in your province, and there's usually an association that might be able to provide some of this support for you. Some tips is obviously to maintain a healthy body weight and good skin care, and really try to avoid injury. So just really controlling the volume of the affected limb, and compression garments can really make a big difference with this. So I'm going to actually pass this over to Marilyn now, because she has some tips from a local survivor that has been dealing with lymphedema and wanted to pass this information from what she's learned from living with lymphedema. So Marilyn, I'll pass it over to you now.
Thanks, Krista. And just to let people know, we will be getting to your questions as soon as I'm finished with this short conversation around lymphedema. And this actually came up because a woman approached me about the fact that she was struggling with leg lymphedema as a result of her ovarian cancer. She's interested in connecting with other women who are experiencing lymphedema themselves. So if there is anyone online who does have lymphedema or has struggled with lymphedema, and you're interested in connecting with other women across Canada who are dealing with the same issues, if you want to just type in the chat box that yes, you have lymphedema, or you can contact me privately after the webinar. Bev is interested in talking with other women who have dealt with these same issues. And she's learned a lot through her own research and her own experience, and she really wanted to share some of these things with other women who might be dealing with the same issue. So I'm going to go through some of this and just some of the things that she wanted to share. And so she felt it was important, as soon as a diagnosis of lymphedema occurred, that if you didn't receive a referral to a clinic, to get that right away, or as Krista has suggested, contact a lymphedema association in your province as soon as possible. Elements of treatment that Christa's talked about is elevation to prevent the swelling, lymphatic massage, exercises, and compression garments. And Bev said, you know, these none are mutually exclusive, none are guaranteed to prevent tissue damage, but this is what is available, so if you need to, do all of it. At the onset of leg swelling, it's important to get a Doppler ultrasound as quickly as possible to rule out any deep vein thrombosis. And then if there is no deep vein thrombosis, you can buy compression stockings at the drugstore. And there's different levels of compression stockings that Bev discovered. One is the over-the-counter ones that you can buy with no prescription, and you can buy those right away and begin to get relief from that. If swelling continues or the over-the-counter ones don't work as well, you can get a prescription for ones that have a higher compression that may work better for you. You can order those online and they can be delivered very quickly. The provinces, you will have to check this out in your own province, but there can be provincial government assistance for compression hose because they can tend to be quite expensive. The problem with that is they can take a long time to get them. So if you can afford them, buy them over the counter as you're waiting for ones to come through the government assistance program. You will need certain forms that may vary from province to province. In Ontario, for example, you need a form signed by 2 different healthcare providers, and you need to visit a licensed fitter who would actually order them for you. And your provincial government may pay a certain percentage, and there will be criteria and limitations to what you can order and when. Compression hose, these were some of her take-home messages. As I've just said, don't wait for the government subsidized hose. If you can buy your own, get them as soon as possible. And some private medical plans may help cover some of the cost. If you have a medical plan or an employer plan, you may find that some of it is covered. Another type of compression hose that she has found is called compression bandages, which is not tensor bandages, just to be clear. And this can, you can adjust the tension and pressure more so than the other types. And she found these helpful, particularly if you're flying on a plane. Um, as you know, sometimes just for the average person, legs can swell and so on when you're flying, and so that can be particularly difficult for someone who's dealing with lymphedema. So in terms of travel in the car, be the passenger if possible. Sit in the back so you can elevate your leg. Similarly, if you're traveling in a bus, if you can sit in the rear seat to elevate your leg. And she found elevating her leg as much as possible for as much of the day as possible was helpful. She also learned that if you do have to fly, WestJet, um, you can actually get a free extra seat on a plane for your leg so that you can elevate your leg during the flight. And there's information on how you can contact WestJet to do that. Air Canada does not offer a free seat, but you can buy a second seat for that purpose, but you also need to apply through them in order to do that. Um, this is also what she's learned. The swelling accumulates at the lowest point. So if you sit with your leg elevated for much of the day, that fluid is going to accumulate in your butt. And that can lead to chronic skin changes there. So there are things to be aware of that she has learned, as she would say, the hard way, and really wanted to share these things with other women because it took her a long time to sort out some of these things. And these are some of the things that she's looking at, and obviously hoping new treatments will be developed. And by preventing the swelling, if possible, you know, that can help prevent permanent tissue damage. So if you have lymphedema and you are interested in connecting with other women, please let me know that either through the chat box here, or as I said, you can contact me privately after the webinar. I know Bev would love to connect with you. And so now we are going to take your questions. I want to thank Christa for all that information. That was amazing. Thank you, Christa. And the first question here is I'm interested in the chemo side effects that last a long time, or what are called late effects. I experience cognitive issues and fatigue still after 1.5 years after chemo. So Christa, what would you say to that?
Unfortunately, that can happen. It's not common, but when it does, it can really affect your quality of life. We unfortunately don't really have much treatment available when it gets to that point. With continued brain fog and fatigue, although it does typically resolve by the 1 year mark, sometimes it can linger longer. It does still usually go away, but it also depends on what the ultimate cause is. Sometimes there's underlying issues that are causing or potentially aggravating the symptoms. So it's really talking with your family doctor as well, because sometimes there's other issues that are potentially causing the fatigue and confusion or concentration issues, and we don't want to be missing something else that can be potentially treated just while assuming that it's from the chemotherapy. So it's really important to make sure that you're discussing with your family doctor about any sort of thyroid issues or other different sometimes you might have some sort of deficiencies, but there's a variety of other potential causes. So just really making sure that there's nothing else being missed. And then focusing on sleep quality, making sure that you're having really good quality of sleep, because that can greatly affect your concentration and fatigue levels during the day. And talking with your family doctor or your gyne-oncology team for support with that if needed, because that can really make a huge difference. The other long effect that we see is the peripheral neuropathy, unfortunately. It does really tend to improve over time, but not for everybody. So that's one of the most common side effects that we do tend to treat chronically through cancer care. Family doctors definitely have the ability to help with that as well. So if you feel more comfortable with your family doctor, then they can help as well, and really fine tuning and finding what treatment works specifically for you. So those are the most common that we do tend to see for late effects. But was that helpful, or any other questions about that at all?
The next question is also actually about neuropathy. Just wondering how long neuropathy would take to heal. Does it heal completely?
Yeah, so
I don't know if
unfortunately it
there's
doesn't
anything you want to
always.
add to what you
Um,
just said.
yeah, um, it's really time. That's one of the biggest things. Sometimes we actually start treatment for the neuropathy if it's really affecting someone's quality of life during treatment. But we try to wait if we can, because the hope is that time will allow the neuropathy to improve. But sometimes it doesn't. Sometimes the neuropathy is something that people have to live with for the rest of their life. So that's why while you're on treatment, it's really important that you're keeping track as to how bad the neuropathy is, which knuckle does it go down to, how far up the foot does it go, and as long as you're keeping your gynae oncology team basically in the loop as to how severe it is. If it's coming and going is also a huge issue. If it's consistent and persistent and not really coming and going, that's a little bit more so concerning that it might become a chronic issue. If it's coming and going and more so worse after treatment, but tends to resolve itself and just get to the tips by the time you're due for your next cycle, much less concerning that it's going to become chronic. But once it gets to the point where it's not coming and going anymore, especially if it's starting to get to the base of the forefoot and affecting your safety, or starting to get down to the second knuckle and affecting your ability to do up small buttons or earrings, then they really should start looking at decreasing the dose of the chemotherapy, especially the paclitaxel. Sometimes having to drop the paclitaxel because it's typically the most common cause. Carboplatin can cause it, but it's usually the paclitaxel that's the culprit. So there are ways that we can try to prevent it from becoming worse, but it's just really making sure that your team is aware that it is getting worse, so they know not to be giving any more of that harmful chemotherapy that's potentially obviously the cause. So.
Christa, I've had an inquiry just recently from a woman about neuropathy that set in many months after she was finished treatment. And I wonder if you can comment on that, as well as one of the drugs you mentioned. Is it called gabapentin?
Gabapentin, yeah.
Gabapentin,
So
yes.
the when people do still have it at the 3 month, gabapentin, yeah. When people do have neuropathy still at the 3 month mark, then they do tend to um, be more likely to have it for the rest of their lives, actually. So it can still diminish over time, but they're probably going to have a certain amount of peripheral neuropathy for the rest of their lives. So that's when, if it is affecting quality of life at that point, or activities of daily living, we do typically recommend medications such as gabapentin or nortriptyline. I tend to lean more towards the nortriptyline because it's actually an antidepressant as well. And if anyone's having any issues with depression at all, it can help with that. It's also a really good sleep aid. It tends to help people that have sleep disturbances. So, and it's just a pill that you take once a day, whereas gabapentin is a nerve medication. So there is good results with gabapentin, but it's 3 times a day, and it has a little bit more fatigue related to it. So really with any medication, there is potential side effects. So we do try to avoid using medications if we need to, but at the same time, if we can help improve the quality of life with medications, then there's definitely lots of different options. It's just sometimes fine-tuning which options work best for each individual.
And there was also part of that question around fatigue, still experiencing fatigue a year and a half after chemo.
Yeah, that one we don't see very often. It can happen, and when it does, it can be very frustrating and debilitating. So I think at that point, it's really important to be leaning on your support network, whether it be family or friends, or the support network through your local cancer care. Typically, you have access to social workers for counseling. In Manitoba, anyways, it's for the full 5-year follow-up phase, because sometimes it is those chronic effects that tend to really bother people. When you're actively on treatment and dealing with side effects, people tend to be a little bit more tolerable of them because it's acute, it's something that's getting you through your treatment, and you know that there's kind of an end at the end of the tunnel, or a light at the end of the tunnel. But when you're dealing with a chronic effect like that, that can be really frustrating and debilitating, especially depending on your career, if you're trying to get back to work and whatnot. So I think really leaning on the supports in your network and your community, and the counseling services available through your local cancer care can help with that, and also leaning on survivors that you can connect through Ovarian Cancer Canada, or your local community, because a lot of them understand what you're going through, and talking with someone that's been through similar experiences can help with your overall coping of the situation.
Okay, this is the next question. Is it true that chemo can live in the fat stores in your body and that if you lose weight, you may experience side effects?
Oh, I've never actually heard that before. That sounds really interesting though, so I'm going to look into it. But no, that's not something that we typically um, hear of anyways. I'm not going to say that it's not possible, but that's not something that we've ever really talked about as a team here at Cancer Care. So, but I'm going to look into that. That might be a theory for sure. I don't know if that's ever been proven, because that doesn't necessarily affect our overall treatment for people after they're done chemo, or our assessments. It's never come up on the radar, but I am going to look into that though, because that does sound like a potential theory that I'm just curious as to whether or not there's been any proof for that. But we haven't heard any of that anyways through cancer care.
Okay, thanks. Next question
No
is,
worries.
I'm required to take high doses of steroids the day before chemo. I'm allergic to Taxol. Does this increase my chance of having these side effects you are talking about?
No, actually, with the steroids, the main side effect that we see is difficulty sleeping, actually. So it can definitely help or cause problems with sleeping because of the high dose of steroids beforehand. That's not something that we do typically, but if anyone has a reaction on the day of their chemo, even if it's a mild reaction, we really try to still maintain the first line therapy if possible. So the same chemo medication that you started with. So typically what we do for the next cycle is we call it desensitization, and you can get dexamethasone and or Benadryl for a day or two prior to your chemotherapy, with the hopes to help kind of decrease your immune system a little bit, decrease the inflammatory system in your body in order to help prevent any sort of reaction when you are getting your chemo again for that next cycle. So, but with dexamethasone and Benadryl,
Okay.
obviously there's potential side effects for both. When you take them together, the side effect of Benadryl is sleepiness, and the side effect of dexamethasone is um, uh, uh, not able to sleep. So sometimes those side effects counteract each other, and people are fine with it. But we usually do find that people have issues with their ability to sleep the nights that they take the dexamethasone. So, but other than that, increasing the risk of nausea and constipation, whatnot, we don't tend to find that really um, makes much of an effect. It can affect your fatigue levels and ultimately your brain fog, obviously, if it's affecting your sleep disturbances and whatnot. But from what I know, it doesn't necessarily increase your risk of anything else. It's just, if anything, preventing your risk of um, having a reaction to the chemo, so you can ultimately stay on the chemotherapy that is the strongest and best able to attack the ovarian cancer.
Okay, next question. I'm not going to identify the person by name for the audio because this will be recorded and put on our website. So for privacy purposes, I will just ask the question. I'm finding that the PPE seems to ebb and flow throughout the month between treatments. It is pretty much resolved by the next treatment. Is there any chance that this will become chronic?
No, with PPE typically does resolve, and that's one of the best signs that it's going to that it's what we typically see is that it does usually get worse after your treatment, and by the time you get to your next treatment, the fact that it's already starting to heal is a very good sign that it's not going to become chronic. Sometimes people have a bit of issues with skin discoloration afterwards, but very rarely. For the most part, the skin ends up healing, and we find that there's no issues. It can be a debilitating symptom, though, to the point that sometimes we actually need to um, change treatment or stop treatment. That's very, very rare, though. It's typically in the earlier grades that we grade it that it can be controlled and it's fairly tolerable in order to maintain therapy. So there's actually a really good guideline on the BC Cancer Agency. So if anyone is interested and wants more information on that, it's directed more so to healthcare professionals, but it's a really detailed guideline. If you Google BC Cancer Agency and PPE, it goes through a whole grading assessment as to how to assess PPE and then how to treat it depending on the grade. And it's really helpful for practitioners, but also definitely for patients if you're interested in seeing how we assess it and also then how we would treat it depending on the grade and level of severity.
Okay, we have just a couple of minutes left and a couple of final questions. Can the chemo cause ongoing joint issues, or is this part of neuropathy? She's experienced joint pain in hands, elbows, and feet, which has developed since the numbness receded from the neuropathy.
So joint pain tends to be more of a common side effect while you're on chemo because what happens with chemotherapy is it actually can increase the inflammation in your body, and that inflammation can aggravate any potential arthritis that you had in joints. You might not have necessarily known you had the arthritis yet if you weren't necessarily experiencing the symptoms yet, but arthritis is typically, especially osteoarthritis, is typically from wear and tear and degeneration over the years of use. So the chemotherapy doesn't necessarily cause the arthritis, but because of the inflammation, you might notice the symptoms more so. So if you're starting to get pain in your elbow or your knee, then you might be noticing that you're actually going to be prone to arthritis in those joints later on in life. Sometimes when you stop the chemotherapy, it might not go away completely, but that's typically then from the arthritis that you were likely going to get at some point anyways, and now you're aware as to which joints they're in. So that's usually more often the case. Neuropathy from the numbness and tingling and pain associated with nerve damage is usually more so from the tips upwards, up the feet and legs, and the fingers down the hands and sometimes to the forearms. So very, very rarely will we see any nerve damage that's closer to the center part of your body without it affecting the tips. If it's not affecting the tips, then it's usually from something else, typically inflammation in the body. And if that's an effect that's happening after your chemotherapy, then the chemotherapy might have aggravated it, but it's not necessarily the specific cause. So we usually recommend following up with your family doctor at that point as well to help with any symptoms like that, because a lot of the times it's from something like an arthritis that they're very used to dealing with, and they're the specialists with that in order to make sure that you're comfortable and not just dealing with it because it's a post-chemo effect. It's probably a combination of chemo, but also with a history of degenerative wear and tear from that joint.
And the last question, how long can chemo stay in the body?
Typically, we find that by the month mark is when people are starting to recover from the chemo. So the chemo is physically in your body for 48 to 72 hours. That's when we tell people that they have to be careful with their secretions and their urine and whatnot, because you can actually still have chemotherapy physically in your body at that time. Um, but that's the physical part of it. But the actual dealing with the chemotherapy and the side effects of it, it's different with every chemo. But with carbotaxol, we find that 21 to 28 days is usually when people are starting to feel a bit better, but it's actually still affecting you symptomatically and affecting your blood counts and whatnot, sometimes for up to 6 weeks after your chemotherapy. So it's actually out of your body, but it's just the way that it's affected your cells isn't necessarily recovering until about that 6 week mark. Most people can almost recover by the 4 week mark, sometimes 3 week mark. So that's why we try to do a 21 to 28 day cycle. But it's not fully recovered typically until the 4 to 6 week mark after your chemo.
Christa, I want to thank you so much for the information you've shared today. We just got a little note there saying thank you for the wonderful information. And I'm sure everybody on the webinar has learned a lot that perhaps they didn't know before, and hopefully have learned some things that will help you in your speaking to the women on the phone, that will help you in your recovery. Thank you to all the participants, both on the computer and on the telephone. We appreciate your participation in the webinars. This webinar has been recorded and it will be on our website in 2 weeks. And so you will be able to listen and see it again to pick up any information you might have missed. We will also be sending you an evaluation so that you can give us some feedback on this webinar so that we can continue to improve the information and the way that we are bringing it to you. We have 2 webinars coming up in March. One is on the research impact of Ovarian Cancer Canada's investment in research. That's going to be a great webinar. If you're not registered yet, you still have time to do that. And in French, in the end of March, we will be having ovarian cancer one-on-one. So thank you again. And we hope you have a good day with additional information to help you in your recovery. And again, some of the messages coming in, great job, thank you. Thank you very much, Christa. Thank you. Look forward to the link in the presentation. Great job. And Christa, that's all for you. Thank you so much. Goodbye, everybody.
Well, thank you for having me. Take care.
Bye.
Bye.